Good morning.
Good morning.
So now there is one small problem. Dr. Hamadaki sir will be there for all the advice and he is there. So now we are going with the first case. He is 53 years old, diabetic, chronic stable angina, and his angiography suggestive of double vessel disease, LED long segment, it is tapered lesion around 70 to 80% severity. We can show that picture. And the RCA, there is a critical two tandem lesions. So we are planning to put the Meril's the research product, that is morph tapering stent, in this particular case. So I'll just hand over it mic to Dr. Hamadaki, and he will talk about the approach to this case.
Of course, as you can see, this region length long and proximal part vessel diameter is big, and distal part diameter of vessel is not so big. So this is one problem. How to put a stent? What stent should I use, and how to put a stent for this region? This is one problem, I think. Oh. Could you give some comment about that point?
So good morning, Dr. Hamadaki and Dr. Mahajan, Ramesh Dagubati here.
Good morning.
Good morning. So we have a great panel and actually a room full of nearly 168 delegates from 32 countries. And you are actually the first live operator for this program today. With me on the panel are Dr. Rognoni from Italy, Dr. Andres Josef Ochala from Poland, and Jairam Aital from United Arab Emirates, and Dr. Deepak Kapoor, who is co-moderating with me this session. So I'll ask Deepak, how would you approach this very tortuous LED lesion?
Yeah, good morning, everybody. I'm Deepak Kapoor. Could I see the LED film again in the
Show the film
cranial?
Areocranial.
Yeah, whatever you had in the beginning.
Show the film again. Ha.
So the concern here is, when the lesion is tight, I mean, it's not highly complex. I mean, it's and the length is long. Now, if you are concerned the vessel is smaller distal, the vessel is also underfilled. So you have to predilate an IVUS. That would I will do to get a dimension of the vessel. IVUS will also tell you whether you need debulking, and I think that would be my take. I will pass it on to my colleagues. What do they think?
Andrea Rognoni from Italy. I completely agree with my colleague. I think that a predilation and imaging test is mandatory in this case.
So Dr. Mahajan, there are two diagonals there. I think they are small. Were you planning to protect them or leave them alone? What was your thoughts?
We are planning to leave them alone because their osteas are not that much involved. And we don't want to make the procedure complicated, because as such we have to put a very long morph stent. So tracking of this long stent is sometimes a problem.
So please tell me about catheter and your wire. What did you choose?
The catheter is EBU 3.5 and the wire is run through.
Run through one.
So our plan is to predilate the lesion with a 2.75 balloon and then put a morph, and then we'll do the IVUS.
Will Dr.
We are planning to
Hamadaki
put a morph 3 by 2.5.
Yeah.
Huh.
Okay.
Full din. Yeah.
Yeah, Dr. Hamadaki, will you do IVUS first or balloon first?
In Japan, of course, I was first.
So in Japan, they do IVUS first.
Yeah.
I was ready.
Dr.
I
Uchon?
was ready.
Of course, I was after ballooning is one option.
I think as we have heard in the lecture,
But in our daily practice, we use.
I will agree with the guidelines given to us by the lecture that we can make the difficult case simple. So the most important part here will be a good catheter
If you want, we
support.
can do the IVUS first.
Well, it's almost a good catheter
We'll do the
support.
IVUS first.
And the next thing will be to choose the proper
Give the
wire.
IVUS.
I will choose the extra support wire and then make predulatation first and then IVUS. In my
Will you pre-dilate first or IVUS?
Yeah, I think
Pre-dilate.
pre-dilate.
So Dr. Mahajan, even though Dr. Hamazaki said that the panel votes for pre-dilation first.
Okay, then I will go for pre-dilatation.
Yeah, I mean,
Okay.
I'm Deepak back again. I think you are going to make case longer by cutting corner if you don't pre-dilate before IVUS, because your IVUS may not go in. So I would take a small
Yes,
balloon.
that is the main concern. IVUS may not go and there will be some problem related to ischemia after putting IVUS. So I don't want that thing. So pre-dilatation, stenting, and then post-stenting will do the IVUS after post-dilatation and for optimization.
That's okay. I mean, I would take a small balloon, low profile, just to create a passage for the IVUS catheter and also see what is that diagonal. It is not so small as we think. There is nothing else going to that territory. And yeah, your balloon went very easy. So I think the lesion is is not as tough as we thought.
Yes.
Okay, let's say glories to mosaic balloon. It's a good balloon. Yeah, I have used it for past 1 year, and I think it's a well-built balloon with which compares to the best available in the US at this time.
Oh, slip した.
So we are going at a 4 atmosphere, 5, 10 atmosphere.
でかいね.
Which size of balloon do you use? 2.5?
This is a 2.75, 12, 13.
14?
So after balloon, this is the result.
Yeah, I would do an IVUS now after advancing the wire a little bit, and with IVUS I think we will be able to see what size is the vessel proximally, also deciding on the length of the stent. If you're planning to choose one long stent, maybe 40 or 60 millimeters.
I think this is more for the audience. One key thing is to keep your wire buried into the distal vessel. Because if you lose your wire, you don't want to travel through the dissected plane again. There is a dissection, but balloon is supposed to dissect. And I agree with Ramesh, it's imperative to do an immediate IVUS to identify the landing zone and put your stent. One thing which probably caused dissection is the balloon is oversized for the vessel. In my practice, I will choose a 2 or 2.25.
I agree. I will take a smaller balloon. 2.0 will be optimal, just to make the way for IVUS.
I mean, you are pre-dilating to create passage, not to modify the lesion here.
Unless the suspicion was calcium or something like that.
Yeah, so the only thing is nowadays we are moving with the BRS or MIRES, which we may be using MIRES in this patient. We have to make sure that the vessel is well prepared. There is nothing wrong if you choose a 2.0 balloon or 2.25 balloon, but you have to do IVUS and make sure that the vessel is well treated and well expanded. Without that, in the past, the current generation, 4th generation drug-eluting stents with the thinner stent struts, we might be able to deploy the vessel well, the stent well, and also get good apposition. But whereas the thick struts with the BRS, we have to make sure the vessel is prepared well. We have to do an IVUS first to make sure that the vessel is well expanded before implanting a stent, implanting the scaffold.
There is some problem at our end as far as the IVUS is concerned. There is some problem with our end as far as the IVUS is concerned. They had not brought the catheters for doing IVUS. So we are just waiting for the OCT. So meanwhile, I am planning to stent the lesion and then we'll do the OCT. So we are planning the lesion stenting with a 3 by 2.5, 60 millimeter. We'll just land up in the mid LED and then we'll do the OCT. OCT is organized करना. हाँ, मैं ये IVUS काढूंगे. चल दे, stent दे, more. और
Let's
make the OCT ready. 3 by 2.5, the length is 60. OCT ready kar.
I have a question. Why you didn't do a OCT before stenting? Just to make an idea what is the size and so.
So while we're waiting, sir, just as a panel, from where distally would you start your stent?
Could you put the light a little bit up? Lights up. So let me ask the audience, if anybody want to come furnish their opinion, how will they do it this case?
So plan is to put a long morph. The length is 660 and it is tapering 3 by 2.5 and then we can post dilate approximately 3.25 or 3.5 and distally around up to 2.75.
No. Okay, the concern in the panel is, I think most people here would like to image the artery.
IVUS machine काढून घे, OCTs ठेव आता. सगळ्या पेशंट मध्ये OCTs करू ना.
Anybody speak Marathi?
All the
can
OCTs.
translate. Okay, we understand. So I think under the circumstances, if you have a luminal dissection, it is prudent to proceed with the stent and do not size it aggressively and then postulate or cause proximal optimization.
오, 들어온다네. So there is some problem for
60.
from थोडंसं इकडे.
You want a buddy wire? Or?
Yes, we'll take a body wire and then we'll try to.
Mahaj, do you have guideliner here? That could come to your rescue. Do they have guideliners in India? Or?
Yes, guideliner is there.
Or get your guide to support you well. Clockwise rotate, push your guide deep in and rotate the stent as you go in. That might help.
Yes. Can you give me guideliner? Guideliner.
Hello, Jacob for the Potter.
So we'll use a guideliner only.
I have a question because I didn't notice that. What kind of balloon was it? A non-compliant balloon that you used in the beginning from pre-dilatation? Regular balloon there, yeah.
Regular
It was a
balloon.
compliant
Regular.
balloon, 2.75 compliant balloon.
Okay, and to how many atmospheres did you do?
12
14.
atmosphere.
Okay, I will tell you in the next case what we had a problem with such stent in delivering this stent, and we used a non-compliant balloon up to 24 atmospheres
Guideliner.
to pre-dilatation. In the second case, what I will show you in a few minutes, but maybe this would be a good option for this case. So going with non-compliant balloon first.
So Ajay, the question is, how comfortable are you to take the balloon up to high pressure inflation, up to 24 atmospheres with the mosaic?
How comfortable? I'm pretty
I had
comfortable.
not
but
gone in any balloon. I had not gone about 20 atmosphere. Guideliner.
Okay.
I would oppose high pressure ballooning at this time because you have a dissection. And if you balloon aggressively, you're going to create a further crack.
Yeah.
So I think the prudent thing is to increase your guide support. So clockwise rotate, push the guide deep in, tell patient to take a deep breath or use a guide liner.
Yeah,
I think
yeah.
that
Of
would
course.
work.
This might be an option. Although, yeah, just try it. I mean,
Body
I
wire
would-
is another great thought. I mean, it's an ancient technique, but we still all use it.
If one had to use a body wire, so which one would it be, given the fact that there's a dissection there now?
I would
क्या
stick
मतलब?
with my body parts. I'm very comfortable.
चालेल. गाइडलाइनर पण नाही आणलं का? हा दे ना. हा गाईड. So we are using a 6-step guideliner. 1 point. So balloon ready to. So 2.75.
So in the audience, how many people use guide liner in their practice? Okay. So, I mean, guide liner is also not a panacea. You could have a guide liner back interaction with your device.
So how many people have guideliners in your place? All of you?
So let me-
Mother, daughter? A mother, child?
I think that the question is how many people use a guideliner in this case, and how many people use body wire.
Okay, I think you may have to end up using both. So if you have problem with the guide liner, your balloon or stent does not go. It strikes the back end of guide liner. So one remedy is to preload your stent on the guide liner. So guide liner went in. It's sitting nicely in the LED. You have to be careful about guide liner induced dissection.
How many would start with a 7 French guide system for these sort of calcific cases?
Brilliant. When you have a lesion like this, unknown, I think 7 French is a very good one.
Yeah.
I mean, I think the standard goes back to good guide catheter support. 6 Frenches may not give enough guide support, go to 7 French. And having a good wire, sometimes you might exchange the wire or a micro catheter. And right, so now you can see that Dr. Mahajan has put a balloon, and over the balloon he's advancing the guide liner further down, and that's a balloon anchoring. You can actually inflate the balloon a little bit to 2 or 4 atmospheres and then pull in the guide liner. But all these techniques come at a cost. You know, there may be more dissection, sometimes perforations. You have to be very careful in all that. And now while advancing the guide liner, he will inflate the balloon slowly and then see if it goes further down. Yeah.
Not going.
Yeah, maybe is that enough length? Do you think would you like to try with the stent now?
No, I'll try to just get rid of this obstruction here.
Yeah.
So that's a
There
good
is some-
idea.
So, yeah, I mean, even though in the beginning we thought this is simple, as I said that this is a long tortuous vessel. Those are the ones which don't fall under type A lesion. So that itself is considered as a complex PCI, even though it is one vessel. So my choice of usually buddy wires are Ironmans. I use Ironman as a buddy wire. People may choose something else, but always be careful that when you're advancing the wire through a dissection, you might create a worsening of the dissection.
So now I am trying with another try with the guide liner support.
No. Instead of a buddy wire, the other thing that one could try is putting an extra support guide wire with an over the wire balloon or a micro catheter, just to make sure they don't dissect.
So the most important thing is you have to see the entry point. Show me the entry point of the guide liner. Entry point of the guide liner. Okay. So how the stent enters from this? That is the important thing. Okay.
I think the stent could be a little bit shorter in this case. Not quite distal part, and without any measurement before, it can make another dissection.
So we are just going up. OCT ready करूँ.
How many of you in the audience have used Biomime Morph? Couple of you. Okay, yeah. So I also used same length, actually 3.5. It starts off at 3.5 and the proximal goes down to 3.0 or 3.0 to 2.5. I think here we are using a 3.0 that goes down to 2.5 in diameter and 60 millimeter length.
प्रेशर झिरो कर बरं. झिरो कर. फ्लश करून झिरो. गिव सम सपोर्ट. त्याला सांग ना जरा प्रेशर कमी आहे. प्रेशर कमी आहे. First, 0.
How about the patient, please?
Patient is comfortable. Our the pressure is slightly less. It is in the range of 80s. ECG is normal. Give me NTG.
So whenever you have a lot of equipment, make sure that you flush it. Catheter thrombus is common. You always bleed,
Yes.
bleed back, and make sure there is no damping or suspect dissections. So these are the things that you should come into your mind. Yeah, that's too small distally. You're planning to do any
So
OCT?
this is the result. So now we'll just do the IVAS, do the OCT, and then we'll go for post dilatation.
Okay.
Ready? Ready? File. तेरे को मालूम
Well, the good thing I think is that all the diagonals and the septals are all protected. Nothing's closed off.
We are making everything ready for OCT.
Okay. Would Dr. Hamazaki say that he would have approached this differently? Dr. Hamazaki, how would
Yes.
you
No, no,
how
no.
would you have approached?
Yes.
How would you do this PCI? Would you have done the same way or different?
PCI, no. There is no difference until now.
कैसे कर
So by a vote of hands, how many would have done an IVUS or an OCT before, let's say before putting the balloon and then after putting the balloon? So before putting the balloon, would anyone start with an IVUS? Without the first balloon in place, just an IVUS.
I like
I will probably do the IVUS after pre-dilatation still because it will be much easier to cross it, and this is what I will probably do in this case. If it's possible, of course, an IVUS before everything, what you start to do is the best option, depending on the narrowing, how big is it, and how critical is the lesion.
I would vote for IVUS first without pre-dilatation, because if IVUS does not go in, that's a classical indication for debulking. You take your rota burr if you are comfortable and burr it. The disadvantage of blind pre-dilatation is uncontrolled dissection. And if you are pre-dilating using a very aggressive balloon, 275 is aggressive for this modality. And then your landing zone is not going to be very healthy. So I would vote for first IVUS. IVUS does not go in. What is your comfort level? Use a rota. If you are not comfortable with rota, or if you don't have rota, take a small balloon, small and long. Go only 5-6 atmosphere, take it out, put the IVUS back in. And right now, I think there is a distal end is hazy. but you don't want to change the outflow because the change will end in the tip of the LED. So I think just do proximal optimization and get out of the case.
3.25 balloon, free balloon. So we are ready with the OCT. Twenty cc.
20 cc. 20 cc लिवला.
कोणाला काहीच माहित नाही बरं.
Would anyone in
hai
the
na?
audience have used a different stent size? How many would go with the 2.5 distally and the 3 proximally, or would you use, let's say, a 2.25 and 2.7? I don't know if there is. Would someone go for a 3 and a 3.5? So any takers for a 3 distally and a 3.5 proximally?
Ready? OCT ready?
We still don't know the size of the vessel, so
It's like if you don't know the size of vessel, you can use any size of stent. So if you don't know where you're going, all the roads will lead to your destination.
is it a male patient or female?
If I may comment, I would go for the larger stand because of the proximal LED is usually 3 at least. I'm not afraid about oversize at the end of the stand. It's always the risk of dissection, but it's drug-eluting stand, so I'm not afraid about 10-20% of oversize. And I would definitely go with IVUS first, because not only the vessel side, I prefer to place the stand in a normal part of the vessel. I want to know where disease ends and when is the landing zone for the stand.
Give the 2.75. 2.75 balloon.
So, but this is a 3.0 stent proximally and a 2.5 distally.
Yes.
So,
Yes.
I mean, and I think a 3.0 proximally can be taken up to 3.5 with post-dilatation if need be. And as we see here in the proximal at the 40th mark, the stent is not well deployed, and so obviously he's choosing to post-dilate over there. Ajay, but the question is, can we see the distal edge? Do you feel comfortable with the distal edge on angiogram? And on OCT, we don't see the distal edge yet.
Distal edge, I am planning to just re-image after post-dilatation. The plan is distal post-dilatation with 2.75. So this is a 2.75, just keeping inside. And then we'll proximally post-dilate with a 3.
I mean, you can see the stent struts are well opposed to the wall. In most places, actually in the whole, throughout the vessel. The only question we have is that it is still not well expanded in certain areas.
This is the place where it is not expanded. So we are just dilating it first 2.75 and then we'll dilate with a 3. Give me 3 millimeter balloon.
So what's the minimal stent area in that site that you're looking at right now?
What is the area at that site? At 40 mark. At the mark 40. What is the area there? So I am putting a 3 millimeter balloon.
If I may,
It is a 2.11.
if it's a male patient, we know from many IVUS studies that proximal LAD will be around 4 millimeters big. And the problem with this type of stent and its length, what we have also discovered in our hospital in Krakow, is that if you would go for a bigger diameter
Double
distal,
zoom
you will cause a dissection pretty sure with a 3.0 distal diameter. But in this case, you could go up, surely what you said already, to 3.5. The question is, can we go further to 375 or maybe 4?
Yeah. I mean, one thing is about the racial differences. In Indians, in general, the coronaries are slightly smaller than the Western population. Here, I mean, normally we don't expect a 4 proximal LAD, but obviously if you do IVUS or OCT, it will help you to determine exactly the size before the stent that you have to use, and comfortably how much post-dilatation can you do. And that said, on these OCT pictures, I feel comfortable that the vessel is, the stent is good, but you have to expand the stent a little bit more. My main area of concern would be that to achieve a minimal stent area of 6 millimeters, or at least 5.5 and above, I can accept. Here it is 3.57. So you need to really go up. Maybe we use a 3.5 non-compliant balloon proximally and make it much bigger.
Yes, we will just see the picture and then we'll decide.
Which also makes a point for the debulking there, like Dr. Deepak was saying, you know, sometimes when there's so much calcium, once you put the stent in there, then you're stuck with no option but to just try post-dilatation with the non-compliant balloon. Whereas if he knew beforehand that the calcium was quite severe, maybe debulking would help him at this stage.
That's called stent regret.
I think we should go for OCT now. It looks very clean to me, one ariocaudal.
So you already post-dilated, Ajay?
Yes, I
Okay.
post-dilated distally with 2.75 and proximally with 3 millimeter.
Okay. So we couldn't see those angiograms, I'm sorry. Yeah. And the patient's blood pressure is better now? Or?
Post-dilatation. It is 100 millimeter, ECG is normal. You can show the ECG
And this is a 7 French guide system? 6?
6 French guide system, PA cranial.
I would
what should we now?
suggest that you would do a bit
Yeah,
longer
that's enough. That's
OCT
enough.
pullback if you are doing it
Good.
again, so you can
That's
also take a
OCT?
75
Of course,
millimeters
OCT.
pullback.
Please check OCT.
So you can
Of course.
see the whole stent with a longer pullback.
So Ajay, the recommendation is to go distal beyond the stent with OCT. Obviously, we might have
Yes,
to do
I'm
2
planning that
pullbacks.
only.
I think that in the Sion machine you can also choose 50 millimeters or 75 millimeters, about like that. So one longer pullback would
Yeah, maybe 75 millimeter pullback.
Dr. Mahajan, would you also IVUS or OCT the left main and the proximal LAD, given the fact that that guideliner was sitting there for some time and that you had to push it through?
Okay. Yes, I'll do that.
That's a very good point. If you advance a device into the coronary, guideliner, guidezilla, you are obligated to establish its integrity at the conclusion of the case, because these devices can dissect. And that left main has at least 30% plaque. The osteal LED is also a little concerning. I mean, not hugely concerning, but I would IVUS or OCT.
Flush.
My one suggestion is that when you look for the RAO view, you could see there is some residual stenosis before the stent.
Osteal LED.
So that's what I was suggesting, that we should do IVUS or OCT to place the right spot for the stent.
Yeah, there is a third dimension to coronary anatomy which is not seen on angiogram. So you save on the contrast and use it. Personally, I am in favor of IVUS because a monorail pullback is very rapid. You don't use any contrast. OCT gives you too much detail, which you cannot use. So I vote for IVUS in this case. I'm not seeking perfection. I'm seeking a good outcome.
I'm going to put everyone on the hot seat. Dr. Chala, what percentage of your patients you use IVUS or OCT in your cath lab?
I generally agree for IVUS in this case. Most cases we use IVUS. Only in some BVR cases we use OCT.
Right. No. IVUS, what percentage of your cath lab patients undergo IVUS?
I think in daily practice it's 20-25%.
20-25. And you?
I come from a private hospital where billing is a big issue, so mine's much lesser than that, shamefully.
Deepak?
So I'm in an academic institution. In US, IVUS is not separately reimbursed to huge extent, but my practice is almost 99.9% pre and post IVUS. Now I'll tell you one thing, I'm old now. When I was young, I had IVUS eyes. I knew everything. I knew everything how to handle the word, but as I get older, I realize that I'm wrong. So when in doubt, define it, don't guess it. And I think it's most important to IVUS post-stent. So pre and post, and it will pay you good dividends.
So you are saying you use 99%, but what is the cath lab using in your cath lab?
So my partners, when they start my practice, I'm director of the lab. They are in national trend like 20-30, but within 1 year, they are all up to 90% once you see the outcome.
90%?
90.
So you are actually an outlier. In the United States, the usage is still about 10 to 20%. So you might be pushing it towards the 20%. Now everybody else must be using less than 10%. How about you?
So the thing is that
25%
first I was catheter,
in my center, but
OCT
in this
catheter
case
got
it's
damaged.
mandatory
Now
IVUS.
we are taking another OCT
Pre,
catheter.
before and post-stent. Even before.
But we should generally agree that if you are using IVUS and you make an extra cost, it's better to use it before and after.
Right. So I mean, when you're using it, obviously everybody recommends to use it before and after because you're not increasing the cost of the device. But right now, I don't think in our lab, right now, if you ask me, we probably use around 10%. I might be using a little bit more, maybe about 40%, but not in everybody. But if it is left main, osteal LED, those are the patients we use a lot more. But this patient, even in our lab, I cannot say that we would have used an IVUS regularly in each and every patient. Of course, it's a live case. We want to show something for our audience. We want to do it. That's okay. How many people in the audience would say they would have used what percentage? Less than 20%, more than 20%? How many of you would raise for more than 20% in your labs? Not just yourself, in your cath lab. In your entire cath lab, more than 20%. Only one? Nobody else uses IVUS in their lab more than 20%. So, I mean, the current usage is actually less than 20%. We are trying to see if it makes an, trying to see if we can increase the amount of usage of IVUS, but the studies so far are still not strongly in favor. We are struggling to get some studies out. But in Japan, I think the Hamazaki, what percentage of OCT or IVUS use do you have?
OCT is not so popular
zoom.
in Japan.
Single zoom.
As you know, IVUS is very popular. Maybe use of IVUS is 100%
100%.
in Japan.
In Japan.
Yeah.
I agree. Actually,
Yeah.
I went
As
to
you know,
Japan.
Japanese insurance system is very good.
So I went to Japan to learn
So we
CTOs
can
5 years
use
ago.
IVUS.
So ready?
And my IVUS used jump because they are obsessive over there. They will pre and post IVUS
Ready?
every stent.
I'll inject.
As another question, for IVUS is not routinely used. How many would actually stent this 60 millimeter stent from the stem of the LED?
परच करायचं. Okay.
Can do manual pullback, Jay.
ready.
Sometimes it doesn't come back.
Yes. I'll do that. Ready?
It's interesting what you said, if I may, about the IVUS. 99% of IVUS I understand in the proximal LADs or left main disease or something like that, because marginal branch or diagonals or something like that is
I'll
not
tell you
necessary.
why I use 99%. I don't pay for it. I understand Ramesh said it's not reimbursed, but I don't pay for the catheter. My hospital allows me to pay. It cut my procedure time in half. This case would have been done by now. So you have a choice. You don't want to IVUS, you want to cut corners, you prolong the case. Or you want to, go to the lounge
So
and
there
have
is a
tea,
di-
coffee. So why I use in marginal branch or PDA or PLV? Because I have of late changed my practice. There is a balloon in United States called chocolate. So all the distal vessels, I am not putting stents anymore. I am using the chocolate balloon, which is a different kind of pillow design. It doesn't dissect. So I will IVUS to balloon size.
The residual stenosis has reduced in the area 40.
No, that's this is
I
a
think it is
different
well
length.
opposed. So that should I pull out the wire now?
No, what about that? Go back to 5 millimeters. There is a dissection there, distally, a little bit away from the stent, 5 millimeters. You can
5 millimeter distal to the stent.
Yeah, distal to the stent. You can stop it
Distal
and,
to the stent.
and take it to 5 millimeters.
Okay, 5 millimeter. Take at 5 millimeter.
Right there.
this
Right
is-
there.
Oh,
Right there. So,
Huh.
so there's a dissection at the 7 o'clock mark. Go beyond slowly.
Yes. Go beyond.
Back. No, the other way.
Go beyond.
No, go the other way, Dr. Mahajan. Rewind.
No, go
other way,
Go
other
to
way.
distal part. Go to distal.
proximal.
Yeah.
Go away. 5. Go. Go back. There is a resection here. Go back. You have to go that way.
So the question with IVUS OCT is how many would you leave it alone now?
You have to go this way.
So everybody
Zero, towards zero.
everybody
You have to
says
go
leave it
towards-
alone. So I would say pull the wire
Okay.
back and wait for 5 minutes and do an angiogram
And then
again.
Oh. Okay. If there is a flow limiting, then we have to.
I mean, so there is a data we don't know. OCT shows beautiful dissections. And now what to do?
Yes.
Does it, all dissections need to be treated? The answer is no. If it is more than 270-degree arc of dissection, those patients are treated. But this is all coming, new data that's coming up. We don't know. There is no consensus. If you ask Patrick Sarayas, he'll say every 270-degree
Double zoom.
dissection has to be treated with a stent. But we really still don't have a great idea about this.
Yeah, but Ramesh, you cannot stent that outflow. I mean, stenting is not a great option in the distal
That is
outflow.
because of mismatch of the size.
I mean, it is 2
I think it should
millimeters.
we should have used the 2.75 into 2.25 morph rather than 2.5. 2.5 for distally it is slightly bigger one, and after post dilation to 2.75 it might have lead to the distal edge dissection because of some shortening of the morph. RO caudal.
Yeah, I agree. Give
So
2
distal edge
P3A.
will get exposed.
I mean, this is femoral, which is not my usual way. Otherwise, actually, I do 2B3A for radial approach.
Square.
And we'll just stop it right there.
I think that angiographic image of this section is very bad.
UV wire. UV wire.
Dr. Mahajan, there is a concern that the distal flow in the LED has slowed significantly.
One second. Show me prior shoot. Sin minus.
AP cranial or
Sin minus. Ha.
Can you take that picture again? Have you just focusing on the distal more?
Okay, I'll take picture again.
AP cranial.
So PA cranial. PA cranial. Okay.
And show us the distal, yeah. Go down distally, yeah. Dr.
It is a
Hamazaki, what do
Dimitri
you
flow.
think?
Yeah, I think no problem.
Give 2B3A.
We can leave it.
Yes.
2B3A should be given.
Now we'll just do one angio on right side and we'll just take the opinion of the house. Is there any need to do it or not?
Okay, so we have to move on, Ajay, as well, but please give us an update when you come back here again. Thank you very much for showing this patient with the complex LAD lesion using good guide catheter support and also guide liner. Thank you very much, and OCT use as well.
Thank you.
Thank you.
Thank you, sir.
And thanks to Dr. Hamazaki as well.